All right, we're going to get started with this lecture. We're going to be talking about neurological disorders. This will go towards your continuing education for the next recertification cycle. So we're going to talk about what the neurological disorders are, where they can be located at, what can be the causes of them, talk some about altered mental status, neurological deficits, and manifestations of the nervous system disorders. We're going to talk some about the pathophysiology in hopes that you can understand a little better what's going on with patients having seizures and strokes specifically. So the nervous system and the endocrine system are two major control systems of the body. They work together. In the nervous system, you have two divisions. You have the anatomical and then you have the functional divisions. So anatomically, you have the central nervous system, spinal cord, you have peripheral nervous system, which is going to be all the other neural tissues throughout the body that's outside of the brain and spinal cord. Functionally, you have somatic and voluntary, which is voluntary function. You have autonomic, which is involuntary function. So examples of autonomic would be breathing, heartbeat, vasculature, dilation and constriction to control blood pressure. And your somatic or voluntary muscles is actually think, I want to pick this cup up. So you reach over, you grab the cup, you pick it up. This is kind of takes you back to EMT or paramedic school, talking about the different receptors throughout the body. The nervous system, along with other systems, are dependent upon these types of receptors. So you have alpha-1 receptors, beta-1 receptors, beta-2 receptors, and there's also alpha-2 receptors, but it's not relevant to this. And you have your parasympathetic responses here. So your alpha-1 responsible mostly for constriction of arterioles and veins and pupil dilation. So that's alpha-1 is going to be arterial venous constriction and pupillary dilation. Beta-1 receptors are going to be responsible for increasing the heart rate, the strength of contractility, automaticity, and conductivity. So it's going to be something that just helps to speed the heart, make it beat faster, make it beat harder or stronger. Your beta-2 receptors are going to be bronchodilation and also dilation of arterioles, and it's also going to inhibit uterine contractions. So therefore, this is a smooth muscle relaxer. Typically, we give the beta-2. We think about our asthma patients, our COPD patients, and things like that. And that's where that comes into play. Then your parasympathetic nervous system is responsible for pupillary constriction, decreased heart rate, the strength of contractions, your blood pressure, bronchoconstriction, increased gastrointestinal tract activity. So if you think back again to school, your parasympathetic is what kind of slows things down, responsible for the feed and breathe, whereas the sympathetic is responsible for the fight and flight. So the function of the nervous system is basically to monitor the environment, to the body's surveillance system, so to speak, keeps track of what's going on around you within your body, and based on the information that it received, is going to produce or cause reactions and regulatory functions to occur to help maintain homeostasis. And this consists of both the voluntary and the involuntary responses. Just a quick look here at the neuron, if you can remember this. Um, the neuron is made up of specialized cells, nervous cells. You have the dendrite, you have the body, you have the axon, and then the terminal ends. And they're more or less, this is what a cell, neural cell would look like. And they're lined up with each other. So the terminal end is going to be next to the dendrite of another nerve. And the way that this works is through the chemicals that we'll talk about shortly that innervate different responses to create different signals to travel up and down the nerve fibers. So at the synapses, it's a gap between the axon and the dendrite. This is where a lot of the neurotransmitters work. So molecules, the neurotransmitters are secreted into the synaptus, which binds with the receptors on the dendrites. And based on which molecule that is going to determine what response you get. So the neurotransmitters also secreted into the synapses. They must be broken down to prevent continuous stimulation. So basically that's talking about the neurotransmitters more or less have a half-life. So when one is secreted into that space, it only lasts for so long and it's broken down. And in order to have a continual response, then your body has to continually put that neurotransmitter into place. But you want that ability because you wouldn't want to have a stimulation there that wouldn't be broken down. Then you would have a continuous stimulation to the point of detriment. So just some quick overview of the brain. We're not going deep into this. But you can, the different parts of the brain you can see here. Take note of the structures and densities that are here because each part plays a significant and yet a different part, a different role in the body's response to the environment around it and its response to various stressors. So here are neurotransmitters. Again, we're not going to go deep into this, but just a quick overview. Acetylcholine is one that we hear about a lot. Acetylcholine is responsible largely for that parasympathetic nervous system response. So what it does is it helps to slow things down. I talked about that a little while ago in a previous slide. So it helps to slow the body down, get it ready for rest, for digestion, for the processes that the body needs to maintain itself. Dopamine is another neurotransmitter that we hear a lot about. It works in more than just the brain, but in the brain it is very important. It is responsible for movement and motion. It plays a huge role in addiction. When someone develops an addiction, it's usually going to be because whatever that substance is causing dopamine release, which causes you to be happy, and it causes feelings and responses that your body likes, and you get dependent upon those things to continually have that dopamine readily available and producing those effects that your body desires. Very important here also that the death of dopamine, as you know, or as you note here, can cause the Parkinson's disease. So as we lose that ability to produce the dopamine, we start to get those tremors. We start to lose that ability to have those fine motor skills that you see so often in Parkinson's. But it also makes sense too, in Parkinson's patients, there's a lot of different things as well that go on with their mental capacity as far as depression and anxiety and things like that, not only just because they have the disease, but also because they lack that dopamine, which causes you not to be depressed, which helps to stabilize those things. And so patients with Parkinson's and other such type neurological issues end up on antidepressants and antipsychotics. And how they work is by increasing or decreasing the dopamine activity in the brain, depending on what is required. So, this GABA is also another important neurotransmitter. We don't typically hear a lot about it, but it is important. Um, as you see here, it a huge role with anxiety and insomnia. And we look at our benzos and things like that help to decrease anxiety by stimulating the GABA receptors. So when we see our patients that are on these types of things, it's good to remember that it's not just a mental issue, that it is actually a chemical imbalance, and they need these medications in order to function properly and to not suffer the effects of the anxiety, the insomnia, depression, or psychosis in a lot of ways. To continue on with our neurotransmitters, we have glutamate. It plays a role in learning, in memory. Um, Deficiencies here are related to Alzheimer's disease and alcoholic brain damage. So as we age, if you have the unfortunate path of developing Alzheimer's, this is how this affects you. Um, for chronic alcoholic brain damage, this is also what happens. Your body is unable to utilize, produce this glutamate properly, so you impair your ability to remember, you impair your ability to learn and make new memories. Um, Moving on to norepinephrine is another neurotransmitter that we do hear about somewhat. We think of it a little bit differently than what we see here, but this helps to regulate the reticular activating system. If you think back to the brain that we saw shortly ago, the reticular activating system is deep within the brain. It's near the pons, and it is responsible for a lot of primary functions of the body. So you can have a lot of anxiety issues related to this, um, and depression, but as well as the stimulation of some alpha and beta cells, it controls, as we remember, vasculature and heart and lungs. So norepinephrine is another one that plays multi roles, but specifically in the brain does have to do with depression, um, and anxiety. Serotonin is another one that we are very familiar with that has a lot to do with mood, emotion, appetite, and sleep. Um, a lot of people may take serotonin and melatonin to help with some of this. Um, the lack of serotonin also can lead to depression. And so people are put on antidepressants. They do have some that are selective to the serotonin, um, to help block the reuptake of the serotonin at the synapses to help control those issues. So the brain consists of these parts, major parts that we saw in the previous pictures, and I've alluded to a little bit. And each one, again, has a specific and a different function. We're not going to go deep into these, but if you're not familiar with the functionality of each one, I would suggest that you look into it a little further. But we're getting ready to do a quick overview. So the frontal lobe is is for thinking, problem solving, reasoning, judging, personality, It is who you are. And that's why when people get concussions, that a lot of times they have issues with some of these things. They become aggressive. They can forget things, have problems with reasoning, problems with problem solving, because that part of the brain has been damaged momentarily. The temporal lobes on the sides are responsible for hearing, verbal memory, and visual memory. And you see right versus left, which is another thing whenever you are assessing for stroke. If you remember these items, when people have issues with um, cognitive abilities, you know that it could be frontal. You know, if they have problems with verbal memories, you know, not remembering sounds or things, and it could be the left side temporal, or visual effect could be right side temporal. Your parietal lobe is responsible for touch, your various senses, balance, interpretation of sensory information, understanding of spoken and written languages. So this would be effective whenever they're not able to say, you can't teach an old dog new tricks. Your occipital lobe is for visual information. So it receives the information from your eyes. It interprets that information. It analyzes it and everything. Your cerebellum maintains muscle tone, coordinates movements, helps maintain balance and posture. So we're getting a little bit lower in the brain here. The medulla oblongata, it is responsible for basic life-sustaining functions of your body, your breathing, your cardiovascular. Um, it is the part that interacts the higher brain from the central brain and the lower brain, the spinal cord. It controls skeletal muscles, um, a lot of things here. The pons is the relay center between the higher brain centers and the spinal cord. It's responsible for the regulation of respirations. The RAS, reticular activating system, talked about earlier. Nerve fibers within the hypothalamus, thalamus, medulla pons, midbrain are responsible for relaying the sensory information from the spinal cord and maintaining consciousness. So this is a small area in the brain that has a lot of important functions. The amygdala is part of the limbic system. It plays a role in memory function and emotional reaction. The thalamus is the relay center between the cortex and the sense organs. Hypothalamus controls hunger, thirst, temperature, and aggression. It interacts with the pituitary gland for integration of nervous and endocrine control. So the hypothalamus we hear about, we think about, but not a lot, but it is integral part of the nervous and endocrine control. So when you have problems with the hypothalamus, these are people that, you know, have hunger and thirst issues. They'll have a lot of aggression issues. They're unable to control their body temperature. They can get really hot. They can get really cold. Have lots of different issues, and not to mention they can have many issues related to the endocrine system as well, because there's lack of control based on nervous stimulation. So the nerves may know that something needs to change, but it's not able to relay that information to the endocrine system because there's a problem with the hypothalamus. So as we assess our patients with neurological complaints, it's just a normal assessment we go through really, but we just have to keep in mind some of the things we were just talking about. So when people have altered mental status, behavioral changes, sensory impairments, headaches, weakness, paralysis, or any other complaint, we need to be aware that there's lots of different reasons that these could be occurring, and we need to ask questions and dive into areas um, that could help to provide some of the answers to those questions. Obviously, our scene size up. We're always looking for safety. Always want to, know how many patients we're dealing with. A need for additional resources. Um, Usually with neurological complaints, unless you have a biological agent that's involved, you're usually only going to have one patient. If you have more than one patient, then that should be red flags anyways. Um, Scene safety is what it is nowadays. Whether it's medical, trauma, domestic, whatever, you always have to have that in the forefront of your mind and think about it. Additional resources. Although you have one patient here, it is important to get on that early if you need help. Maybe it's help moving somebody. If they are having a stroke or other, serious neurological issues, they may not be able to control their body. You may have just a dead weight that you have to deal with. Depending on your crew makeup, you might need additional help. These people tend to be, on the second or third floor in the back bedroom around three or four corners and whatever. So we need to make sure we get that additional help there, not only for those reasons, but also for care reasons. We don't want to spend a lot of time on scene caring for sick people, although we have a lot of things we need to do. So it might just be that you need additional help because you need a third rider because you have a lot of things to do and you need to do those en route to the hospital rather than staying on scene, wasting valuable time. So you can multitask when you have another couple of hands helping you do that. We're looking at our nature of illness or mechanism of injury as always. Um, and with every patient, you gather your general appearance as you approach, you assess your mental status and your chief complaint. Depending on the patient and what's going on, you might not be getting this information from the patient. It might be a family member or a bystander, but if there's no one there to provide you that information, you're obviously going to have to um, gather your information based on a good and thorough assessment of this patient. So your primary assessment, you have an unresponsive patient. We're going to check for pulses always, check the carotid, check radials even. If you have a good carotid, you check for radial, you got a good radial, then you know you got a decent pressure. Um, if you don't have any of those things, we begin resuscitation, which is a totally different class and lecture. We are not going there today. We're going to determine the level of responsiveness using our AFPU. If we remember, A is alert. That means when you walk in the room, they know that you're in the room. V is verbal. When you walk in the room, they do not realize you're in the room, but you can say, hey, sir, hey, ma'am, and they respond to you. That is verbal. Pain. That is when they do not respond to your presence. They do not respond to your voice. You have to physically stimulate them with a sternal rub, pinching the ear, pinching the nail bed, things like that. Unresponsive is obviously unresponsive when they respond to none of the above. So our patients with our neurological problems, they could be deeply unresponsive. They could be at any level of this responsiveness um, assessment. For those that are deeply unresponsive, we need to be concerned about maintaining their airway and ventilations. Again, we don't know yet what's going on with this patient, what part of the brain is involved, what led up to this. So when you have that unresponsive patient, we're going to be aggressive with airway management, not in providing an advanced airway per se, but making sure we maintain what we have. Use the MPA, use the head tilt chin lift, um, keep the bed at 30 degrees or higher, assist ventilations as needed, provide a BVM. In all these patients, you do need to do capnography because you need a way to, number one, measure their end tidal so that you can measure their body's ability to process and use oxygen, as well as you can maintain constant awareness of breaths per minute, um, whether they're breathing deep or shallow. If there's any patterns that may arise or any changes, you can see that breath to breath. So you really need to have these patients on capnography. I'm going to protect that airway like I just said. get the ABCs, provide oxygen, um, never withhold oxygen if someone needs it, but we still have to be careful at over oxygenation. So we're using and relying on pulse ox, um, skin temperature, blood pressure, entitled CO2s, and other assessment tools to determine how much oxygen we're going to give people. We are past the time where everybody gets a non-rebreather. There is evidence that shows that free radicals from over-oxygenation with people with cardiac and neurological issues specifically can cause long-term damage. So we're going to maintain that pulse ox between 94 and 99%. We're going to prevent that secondary brain injury from poor perfusion, hypoxia, and hypoglycemia. So as we assess these patients, we got to make sure that we do get that blood glucose level, we get that capnography, we get a good blood pressure, and we're maintaining these things for that patient. When we get the blood pressure, we need to really be looking at our MAP. MAP is beyond this discussion of this presentation, but the MAP is important, probably a better number for these patients than an actual blood pressure. So we're going to obtain, a medical history as best as we can. If we have bystanders, if there's nobody there that knows anything, you have to be the investigator. Remember looking in a bathroom, in the refrigerator, in a cabinet. We got to find medications with the patient's names on it. See if you can find old medical papers or whatever, discharge paper from the hospital or from a office visit or something to help to provide information if there's no one there that can provide that information using the sample on OPQRST. We're always going to consider the increased intracranial pressure, um, and you need to be familiar with this concept of the cerebral perfusion pressure. Our critical patients, we got to do a rapid physical exam just to make sure that there's nothing else going on. Just because somebody presents with a neurological issue does not mean that there's not a traumatic issue as well. Did the patient fall? Did they hit their head? Did they bite their tongue? Did whatever? Did they fall on something hot and now they have a burn? So we need to make sure we do that quick assessment to make sure that we're not missing anything. For non-critical patients, we always have the ability to do that more focused and detailed exam to thoroughly check out and to see what's going on. Um, just one more note, going back to the intracranial pressure and cerebral perfusion pressure. So intracranial pressure is the actual pressure inside of the cranial vault. It's made up of every component that is in the cranial vault. The cerebral perfusion is the pressure that is left over once you take away all the other pressures that accounts for the blood flowing through the brain and its ability to perfuse the brain. And that is why MAP is important here. So as we continue on with our exam, we're going to do a neurological and mental status exam as long as the patient is able to do that. They're unresponsive, they're unresponsive. There are things that we can do to check some things. We're always going to look at the pupils. The pupils are hugely important with neurological issues. It can give you a lot of information. Um, we can assess our motor and sensory function in all four extremities. Um, if they're able to participate, that's a fairly easy assessment. If there's somebody that's unresponsive, this can be done with a pain response. If you elicit a pain response from a patient, you can check each extremity with the same type of an assessment. Use our stroke screening tools. We'll go over shortly those, and determine a Glasgow Coma Scale. Glasgow Coma Scale was designed and developed for people with neurological issues to give a long-term prognosis of that patient. So there's various pre-hospital stroke screens. I'm not going into detail into any of them, but just a quick overview. This is the one most people are familiar with. This is Cincinnati Pre-Hospital Stroke Scale, and it consists of these three elements: facial droop, arm drift, and abnormal speech. It tells you here how to do this. So we're going to have the patient smile, show me your teeth, and we're looking for droop um, or symmetry on both sides of the face with that. With your arm drifts, you have the patient close their eyes, you hold their arms out, palms up, and ask them to keep them in that position when you let go. And you're looking for asymmetrical drift. A slight drop is normal because, you know, when you hold somebody's arms out and you let go, their body has to take over. But significant drifts or continuous drift all the way down is not normal. So you're at normal speech. We ask them to repeat. You can't teach an adult new tricks. We're listening for slurred words, correct words, order of words, the ability to even process that information. Here's another one we've heard of, but a lot of people aren't super familiar with it. It is more detailed. Is the Los Angeles pre-hospital stroke screen. It has other considerations in addition to what we just talked about. And we're looking here, we get this information, but we don't typically think of it as a part of a screening or as this tool per se. But it helps to provide prediction of outcome and severity. So here's your Glasgow Coma Scale. You need to be familiar with all the components of the Glasgow Coma Scale and its actual intended use. I know that it's something we have to get on every single patient, and therefore I do think that people get complacent to it and don't actually understand all the items, the components that are involved here, and it doesn't account for a lot of people's normals, especially when you go to nursing homes and people with previous issues that have nothing to do with a neurological condition. So eye-opening is 1 through 4. Obviously, spontaneous is spontaneous. This kind of goes along with the AVPU score is a good way you can think about that. So you have verbal, you have pain, and then you have no response. For your verbal response, is a 1 through 5. Number 5 is going to be oriented converses, is just a normal conversation. And number 4 is going to be disoriented but converses and converses. So they're able to talk, but not really sure what's going on. They're having some struggles in that area that is not normal for them. Inappropriate words is number 3. So they may be carrying on their own conversation, irrelevant to what you're saying. It's just not jiving, although they are speaking, you can understand what they're saying. Number 2 is incomprehensible sounds. This is when they start just making sounds, groans and grunts, or trying to speak and can't. And then number 1 is no response. For your motor responses, you have 1 through 6. So you have obeys verbal commands is number 6. They localize to pain, which means if you stick them with a needle, you pinch them, they know, exactly where that happened. They, respond appropriately to that pain. Number 4 is withdrawals from pain. It's deflection. So that's when you go to start that IV or you pinch. That whole limb is withdrawn rather than just a localized reaction. It's more of a unresponsive automatic reaction. So number 3 is going to be abnormal flexion in response to pain. So decorticate rigidity. So it's more like you can think of it like a stretch. So as you do a pain response, start an IV or whatever, they stiffen up and get rigid. Number 2 is going to be extension in response to pain. So this is going to be your decerebrate rigidity. These two are very close together. It's something you're going to see with that intracranial pressure rises, and these are really late signs, really late findings, and it is not good. And then you have no response. So reasoning and decision makings, we need to definitely understand what's going on as we do these assessments, and that's going to help to determine, we should be able to recognize severity based on our assessments, and hopefully if we are familiar enough, we can maybe figure out kind of what the issue is, where it's located. We need to understand things that cause altered mental status, whether it be um, things neurological or things that aren't neurological. We need to understand the behavioral emergencies, things that cause headaches. There are different types of headaches, and things that cause slurred speech. It's not necessarily alcohol, it's not necessarily stroke. There could be other things that can cause slurred speech. So you have your extracranial uh, issues that can go on. So these are things like infections, metabolic problems, hypoxia. Hypoxia is a huge thing. Hypoperfusion, toxins, environmental conditions, and overdoses. Then you have your intracranial issues such as your traumatic brain injury, stroke, and epilepsy. When we're doing our neurological assessment, here is a good AEOU tips mnemonic. We should all be familiar with that. A quick overview, we're looking for alcohol, anoxia, environmental, epilepsy, insulin, which is diabetes related, any kind of an overdose, intentional or unintentional. Uremia is going to be your renal failure, trauma, shock, traumatic brain injury, or anything else. Infection, whether it's inside or outside of the brain, infections can definitely affect the mental status of people. And one thing with infections and the elderly, urinary tract infections can really cause somebody that's elderly to present with a altered mental status. So that is always something we need to be um, asking about with these patients, is if they had any urinary tract infections recently, and question the things about frequency, pain, difficulty urinating that could indicate a presence of urinary tract infection. P is for psychosis and poisoning, and then S is for stroke. So as we assess, we're going to continue to do the airway, ventilation, oxygen assessment and management. We're going to control any bleeding. Usually not an issue when you have just standalone neurological issues, but a neurological issue can lead to bleeding and trauma, so we will have to manage that as well. Blood pressure issues can come on at any time due to various causes and reasons with neurological patients. When we are dealing with stroke patients, we need to make sure that we are taking them to the right facility so that they can receive the proper care. We're going to reassess these patients every 5 minutes that are critical, non-critical patients every 15 minutes. This is a standard across all patient types. And we're going to ask about any symptom changes as we continuously monitor these patients and continuously reassess for changes. Based on all this is going to determine our interventions and changes of interventions. So our continual assessment, reassessment of these patients is paramount. Jumping over into stroke. So stroke is the leading cause of death and disability. Stroke is where the brain is deprived of circulation and thus oxygen and glucose. There are two types of strokes that there are two types of stroke. So you have your ischemic stroke, which is the one we're most familiar with. It is a clot of some kind in the arterial system that causes blockage, and blood cannot flow past that part of the artery. So Anything past that part is going to become ischemic, and a stroke will develop. It's the exact same thing concept as a STEMI in a heart attack patient. So once you have that blockage there, there's no nutrients, there's no oxygen getting past that. So the tissues beyond that will become ischemic and have problems. And the thing is, the brain is delicate. It is not able to tolerate that for very long. You also have your hemorrhagic stroke. So hemorrhagic strokes are it's a bleed from of some type. It's usually going to be that rupture of a blood vessel within the cranium. A lot of times there are congenital things that go on that cause that. This could be a result of uncontrolled chronic hypertension, blood thinners, various other idiopaths can cause these hemorrhagic strokes. So here's just an illustration and a little further explanation of the stroke. So on the left, you can see the hemorrhagic stroke bleeding inside the brain. The blood actually causes irritation, causes swelling, intracranial pressure, damage. And on the right, B, you have the illustration of the blockage. The thrombus has lodged in the artery, preventing blood flow to the distal part of that artery, causing damage. So stroke pathology. On your ischemic stroke, they are often a result of the arteriosclerosis of cerebral arteries or internal carotid arteries that supply the brain. The exact same risk factors as a heart attack. So as these arteries they start to form these deposits and get stiff as well, arteriosclerosis and arteriosclerosis a lot of times goes together. Your stroke risk factors. One of the interesting things with strokes, especially the ischemic strokes, is they are largely preventable. These are huge risk factors, and most of which have a prevention to them. So hypertension, diabetes, cardiovascular disease, a prior stroke puts you at a higher risk. A transient ischemic attack, a TIA, is a precursor to a stroke a lot of times. And when you have those, um, you are at risk of having a stroke within the next few days, of much, much higher risk. Hyper or high cholesterol is a risk factor, as well as with heart disease. Anyone greater than 55 years of age is at risk. Men are more prone to strokes. That is a risk factor that you cannot control. Ethnicity is a risk factor that you cannot control. African Americans and Hispanics have twice the risk of the population as a whole. Um, and that's something to keep in mind when you go to these patients with neurological issues, when they're in these categories, and especially with this family history, then your suspicion has to be really high. Even if it's determined that this is a TIA, then that risk factor has more than doubled, that patient will have a stroke soon. So these are true emergencies. As I said, several of these items you can do things to help prevent, and several of them you cannot. So here are more. You have hypercoagulopathy states, sickle cell, pregnancy, cancer, smokers, obesity, atrial fibrillation, inactivity, IV drug use, specifically with cocaine, excessive alcohol use, hormonal contraceptives, and a history of migraines with an aura. So all these are risk factors, and all of these things we can inquire about as we're assessing our neurological patients. And the more of the things that people have in their common, the more things you can check off, the higher of a risk that person is, and it can certainly lead you down a path to if not identify what's going on, even if it's subtle, to help this patient to prevent from ever having a stroke in the future by being a prudent and a prudent medic and educating that patient. So your hemorrhagic strokes occur to a rupture of an aneurysm in the brain from AVM, which is an arteriovenous malformation. So basically, there's a weakness in that area, and various things, high blood pressure, traumatic things to coup contra coup type things that are fairly mild. A lot of times can cause those things to rupture. Neurological damage and death begins to occur within 4 minutes with these type strokes. So now, as we're assessing our stroke patient, we're looking at these various terms, and these things we need to be familiar with, just because, especially in hospital, you may be asked about some of these, and they're not always easy to remember if it's something you don't use a lot. They a lot of times can sound familiar, they sound the same, and so they can be confusing. So going over the definitions are always good. So aphasia is difficulty with or loss of language skills. It may be repetitive, may be excessive. It can include spoken and written language. So ataxia is lack of coordination. Um, this comes into play if you do the MEND exam or further beyond the FAST. Then you're going to ask that patient to touch their nose, touch your finger with an outstretched arm at various locations, and it looks like severe Parkinson's. So it's just the shaking, lack of that coordination. They may miss your finger, they may eventually get there, but it's not going to be easy. So dysarthria is difficulty speaking due to weakness or paralysis with the muscles. So this a lot of times can be confused with aphasia. Aphasia is the inability to actually speak, whereas the dysarthria is the inability for the muscles to produce the sounds and words that they can formulate in their brain. You have I'm not sure how to say that one, hemianophasia, anesthesia. That is loss of half of the visual field. So they may be able to follow and track. And this is also how you, why you hold up fingers to the side and you're checking for peripheral vision. And if you have a loss of visual field, then that's what you have assessed with this. So you have your hemiparesis, which is weakness on one side of the body, and your hemiplegia, which is paralyzation on one side of the body. So somebody could be weak but not paralyzed. Um, that's the difference with these two. So your TIAs, your transient ischemic attacks, I've already spoken about a little bit. So you have a temporary interruption in perfusion from an emboli or arteriosclerotic disease process. So this is something that comes on sudden and it resolves rather quickly. A lot of times before we get on scene, a lot of it's resolved with 1 to 2 hours. They may still have symptoms when you get there, but the symptoms are gone by the time you get to the hospital. So patients that has experienced a TIA are at a very high risk for a subsequent stroke. They need to go to the hospital. They need to be checked out. Um, and if treated properly and recognized appropriately, we can help to prevent these people, this particular patient group, from actually having strokes, or at least minimize it um, by getting them to the hospital. We need to insist that they go to the hospital. So we have our warning signs, common warning signs of stroke. Really, it's like I have said, your risk factors. You need to know what your risk factors are. You need to mitigate the ones that you can. And if you start having weaknesses, if you start having any of the issues neurologically, then that could be a sign, a warning that something's going on, and those things need to be checked out. You have hemorrhagic The hemorrhagic stroke don't particularly have a warning sign, but when it occurs, it's sudden, and a lot of times it's always been described from everybody that I've heard as severe headache, a thunderclap headache. A lot of times they can hear the sound as that vessel burst in their brain, and then they get a severe headache. They decompensate very quickly, um, and there's really not much you can do for these patients besides early recognition and hope that they have a slow bleed so that you can get them to the appropriate facility to help resolve that. And the appropriate facility for any hemorrhagic stroke that is not in cardiac arrest is going to be Grady. So your ischemic strokes, they usually don't have an onset of a headache. I've never heard of somebody having a stroke that was a headache unless they had a headache before they had the stroke. So the stroke itself doesn't have the headache, but you have the other signs and symptoms of weakness, confusion, the drooling, drooping of the mouth, inability to speak, um, and all those things. A lot of those symptoms are the worst at or near the time of onset. It's a sudden onset, where someone is normal and then they are not. So your treatment, the stroke chain of survival is an AHA term, um, and it is also important. So we're going to recognize signs and symptoms of the stroke, um, use pre-hospital screening tools that we have available to us, support the ABCs. We're going to maintain oxygen above 94%, but we really don't want them to get to 100%. We want to try to keep it below at 99 or below, between that 94 and 99. Um, we need is hugely important. We need to know the time, the onset of the symptoms. When was the last known time that they were normal? If this was witnessed, we want to know exactly what time this occurred. A transport to the most appropriate facility. So again, we don't want to delay transport with stroke patients. We want to do what we can en route because time is tissue, time is brain cells. So we want to get en route to the hospital. We want to get our large bore IVs. We want to be prepared to manage any seizures. And that is one thing that a lot of times you do not have seizures with stroke patients, but there is always a risk of seizures with stroke patients. And you need to be prepared for that. But we want to get our IVs in place. We want to get our screenings done. Always check a blood sugar. The last thing you want to do is go in with a stroke and their blood sugar is in the 30s. You know, at that point, is it a stroke? Is it not a stroke? Not to mention, if it is a stroke, you've certainly not done that patient any good by letting them maintain a low blood glucose. Um, as we treat low blood sugar with these patients, there's something else that we need to make sure that we do as well. The glucose that we give, especially in that D50 form, are large molecules. And when you think back to your cerebral perfusion pressure, um, and you think back to concentrations, this is a highly concentrated medication, and it's a large particle medication. And if we get this person's blood sugar too high, then we can cause damage by that as well. So we're not going to give a half an amp. We're not going to give a full amp just because. We're going to give we're going to give glucose in the form of D50, in the form of D10, whichever you have, and you're going to do that as you monitor their blood sugar until you can get it above 70, and you don't want to hit 150, 200. So once you get that, then that's where we're going to maintain it. And you just have to titrate. You may have to give them a little bit here and there, but we're not going to just push an entire amp of glucose just because somebody's blood sugar having a stroke is low, because you can cause more damage. So these patients are at risk for upper airway obstruction and aspiration. So we have to be prepared for that. We're going to obviously treat any hypoxia, but do not over oxygenate, as I previously have stated. Patients may be hypertensive. We do not treat hypertensive stroke patients as a rule. As a rule, we don't treat hypertensive patients in the field so much. The hypertension, most of the time, is a compensatory mechanism to increase blood flow to the brain tissue. So we're not going to interfere with that. You're going to note that. You're going to monitor that, relay that information. We can start screening for fibrinolytics. Um, they may be started within 3 to 4.5 hours from onset of the symptoms. I do know that in our area, depending on the doctors and the hospital you go to, they may stretch those hours out a little bit, but that is their purview. But nonetheless, our goal is to recognize time of onset, last known well time, and get them to the appropriate facility as quick as possible, not only to meet this time window, but just to minimize damage to that person, to that patient's brain, and loss of function and tissue. So here's a fibrinolytic treatment check sheet, more or less. So your big things is you have to rule out a hemorrhagic stroke. So it needs to be an ischemic stroke. You need to have the patient within the window, and they need to be 18 years or older. There are some exclusion criteria over on the right. Obviously, your active hemorrhage, any bleeding of any kind is exclusion. Low platelet counts, hypertension, uncontrolled with medication. Again, that is something the hospital will address, but we can identify things. Pregnancy, and then minor or rapidly improving symptoms. So the probability of it being a TIA where somebody's getting better, they're typically not going to be aggressive with that fibrinolytic treatment. They're going to be a lot more aggressive with preventative measures, and maybe other types of blood thinners that they might use for those patients. Okay, now we're going to move along into seizures. So seizures is an abnormal discharge or spread of neural activity throughout the cerebral cortex, which interferes with normal functioning. There are various types. You have generalized, you have motor activity seizures, you have people behavioral changes. There's absent seizures where somebody is just um, they're just not there. When you can look in their eyes and it's like nobody's home. So here's some illustrations of a few things. Your aura this is not all patients have an aura, or they don't remember the aura. It can be a very short aura. It could be something that lasts a little bit longer for different people. So if they have an aura that's a little phase before they actually have a seizure. Uh, B illustrates this tonic phase, C illustrates clonic phase, and D illustrates a postictal. And not all seizures are going to be full body tonic clonic seizures. There's so many different types, but a lot of times they will, depending on the history and what's going on with that patient. So we have underlying causes. You may have a history of epilepsy. You might have a history of toxins or drug activity, metabolic disorders, trauma, strokes, tumors, and fevers can all cause seizures. So we need to make sure that we gather this as we gather our information on our patient history. So definitely the key is, has this person ever had a seizure before? If they have had a seizure before, then the next question to ask is this normal? A normal seizure for this patient? Is it an abnormal seizure? And if it is abnormal, then what is different about it? You can gather a lot of information from family and friends of people that have known seizure activity history. So again, you have your generalized seizures, your tonic-clonic seizures, which is a motor seizure involving the entire body. You have absent seizures, as I mentioned, so they may appear simply just staring off to space or daydreaming. They're not arousable. They're just, not mentally there while this is going on. You have partial seizures or focal seizures. It could only affects a part of the brain. It could be motor, sensory, all kinds of different things. There have been people that just an arm shakes, just a leg shakes, could be just eyes. It just all depends on what part of the brain that activity is occurring as to what the manifestation physically is going to be. With our seizure patients, we definitely have to be cautious. They can become injured while they're having a seizure, while they're having tonic-clonic activity. When they become unconscious and fall, they could hit things. They could have all kinds of various injuries. Not only that, when they're having seizures, they can become hypoxic or acidotic. As you have a seizure, remember the respiratory control center is in the brain, and so these patients aren't breathing while they are seizing, but yet they are using a lot of energy because they're using every muscle in their body. All the fibers are using energy. So they're using up sugar, they're using up reserves, they're creating byproducts of all this, and they will become acidotic. Um, so we have to watch out for that. We'll also have to watch out for airway obstruction during the postictal period because they're deeply unconscious at this time, and very likely can aspirate on their drool, on any vomitus, or blood, or anything that could be in their mouth. They definitely need to have that airway controlled and help to maintain that for them. They're not able to control that. So we need to help control that for them, putting them on the side using suctioning or whatever we need to do. We need to administer oxygen as appropriate. If there was an injury, we need to control bleeding. We need to manage injuries, splint, bandage, whatever we need to do for that. Always get a blood glucose level for these patients. The blood glucose could be the cause of the seizure. The blood glucose being low could be a result of the seizure. So we need to make sure that we know what that is and provide treatment appropriate to the finding. Obviously, determine a history if we can. If there's nobody there, do they have a medical ID bracelet, a card, or something on them? They may or may not. Um, it is always good to get an IV on a seizure patient if we're transporting those patients, because if they seize again, then it will give us access to be able to help to treat that. Status epilepticus is a tonic-clonic seizure lasting more than 5 minutes, or consecutive seizures without periods of consciousness. So if they seize and they're postictal and then they seize and then they're postictal and then they seize, and do this multiple times, that is considered a status seizure. Obviously, if they're actively seizing for 5 minutes, that is a status seizure. This is a life-threatening emergency. Just as we spoke about, they will become acidotic. They will use up their sugar reserves and have all the associated issues with that as well. Their brain is not functioning properly, and they will suffer um, long-lasting and permanent um, brain effects from status seizures. So we need to not only early recognize this, but we do definitely need to treat these patients aggressively. So always have that advanced life support there. If you happen to not be an advanced life support provider or have the tools available to you, you need to make that known. At least the incoming unit can start to get prepared for what they are about to encounter. Manage the patient's airway, ventilate the patient as appropriate as needed, um, provide fluids as appropriate. We don't have to call medical control in order to give fluids. But if you ever have questions or concerns about what to do, always contact medical control for advice. Sudden unexpected death in epilepsy. This is somewhat of a new thing that's introduced. So you may not be familiar with this. This does not occur during the seizure, but occurs shortly after the seizure. It may or may not be witnessed. Um, Autopsy findings are varied, so not they doesn't know really exactly what's causing this, but it is something that does occur sometimes with seizure patients. We're wrapping up, getting close to the end here, so we're going to talk about a couple of more things. We have Bell's palsy. A lot of you may be familiar with Bell's palsy, some of you may not, but Bell's palsy is temporary weakness or paralysis of a facial nerve. The presentation looks like a stroke, so you can have the drooping of the face on the side affected. They will be drooling, loss of sensation, numbness. Their eyes may be dry or excessive tearing on that side of the face. So it is a issue with a nerve in the face that causes this manifestation is called Bell's palsy. Um, it can also affect the forehead. It can last for several weeks. It can last for months or years. So there is no guarantee that there will be recovery from Bell's palsy, but it is not a particularly serious issue. It's not a stroke. Um, so you may come across patients that do have the Bell's palsy. That's all we're going to cover in this lecture right now. So if you have any questions, be sure to contact someone in member development. And I encourage you to seek out more guidance, more information on anything that you did not understand or found interesting in this presentation. And again, if you have any questions, let training know. Thank you for your time.